This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is June 2021. We're back again, and really great episode. Ryan, you doing all right?
I'm doing great down here. How are you?
Yeah, it's good. Things are opening up. We're trying to get back to normal life. We're having fun.
Yeah, good to hear.
Our first article is Adverse Events Among Emergency Department Patients with Cardiovascular Conditions, a multi-center study, and the lead author is Lisa Calder. So there's a lot of data on what happens to patients with low-risk chest pain and who we can send home safely. And the short answer is most of these patients do fine. So it's not surprising that we're becoming more and more comfortable managing these patients without admitting them to the hospital. But there seems to be far more uncertainty with other cardiac diagnoses like heart failure, AFib, and syncope. And for these reasons, clinicians are more reticent about discharging them following a negative workup. So these authors conducted a prospective study over 5 years where they examined patients discharged from the emergency department with the diagnosis of heart failure, AFib, or syncope. They conducted telephone follow-up interviews 14 days post-discharge to identify hospital admissions, return ED visits, healthcare provider visits, or new or worsening symptoms. Overall, the authors enrolled 4,741 patients. Of these, they observed 170 or 3.6% of the patients had an adverse event. Heart failure was the highest at 5.3%, followed by AFib at 2%, followed by syncope at 0.8%. By far, most of these events were minor, requiring a trip to the emergency department. A smaller portion required admission to the hospital, and only 4 patients, or 0.8%, died or had permanent disability. Interestingly, all of these 4 patients were in the AFib group. So that is concerning, though the numbers are so small, it's really hard to make anything definitive out of it. It's an interesting study and fairly well done, and it shows that the patients they sent home, at least in Canada, the patients they determine are safe to go home after a negative workup are fairly low risk and do fairly well. Unfortunately, it didn't really help us identify who those patients are, other to say whatever they're doing in Canada seems to be working right now.
No, I thought this was a really exciting descriptive study. I mean, what's most interesting is that the patients that they send home in Canada in this study are pretty sick and pretty old. I mean, these are like people coming in with atrial fibrillation, heart failure, syncope. They're all 70 years old. They're all comorbid. Half of them came in by ambulance. I mean, these are patients that, probably get admitted every single day of the week in the United States. And the ones who went home, we're talking a fraction of a percent, are having really terrible outcomes. And a slightly larger percentage are having, some sort of adverse event. The numbers are small enough and the granularity of the descriptive study is limited enough that you can't say a whole lot about the patterns of the adverse events, other than I would probably go as to say, looking at their small numbers for atrial fibrillation, the main pitfall was just not looking for the cause of the atrial fibrillation or not appreciating the underlying cause. I'm sure there may have been people who looked for the cause and just didn't find it because it wasn't apparent on the index visit. If you look at the people that so-called types of diagnostic error and types of management error that crop up in some of their little anecdotes, it ends up being, they missed the underlying cause, the precipitating agent for the atrial fibrillation, and that kind of led to some of the downstream consequences. Same thing with a little bit of the heart failure, those sorts of things, dual diagnoses, underlying precipitants, underlying exacerbating factors. Which isn't to say that the people didn't look for them, but they missed those diagnoses in this little cohort.
Right. But the question is, was that a diagnosis you were going to be able to figure out in the emergency department? Or is that something that happens, because, as you said, sick patients who are presenting to the ED and are fairly ill?
Yeah, exactly. I mean, sometimes it's just, every emergency department visit is like a single point in space. You don't have a trajectory, you don't have a trend, you don't have evolving symptoms. You just take a snapshot in time and you try and make the best picture out of what you have and try and predict the future. Sometimes these diagnoses aren't apparent until recurrent visit. A new syndrome is just manifesting early sort of non-specific symptoms, and they don't have the cough, the fever, the elevated leukocytosis, and those sorts of things that point you to the underlying precipitant for their atrial fibrillation or heart failure. I love this study as a beautiful descriptive thing. I like the fact that they go into some detail on what they found as far as the different contributors to these adverse events. How does it impact or change our practice? I'm not sure.
Yeah, I think that's the big problem. Like, it doesn't really help us decide who we can send home and who we can't. It is fairly interesting. We've attempted in vain for years to try to come up with like a decision rule to help send these types of patients home, whether it's heart failure or syncope, and they all seem to fail to appropriately identify a low risk group that's safe enough to go home. And then you just have people just sending people home and they all seem to do fine. And so there's a little discongruency there that maybe simply just putting in the people in the hospital, you just observe more events and record more events. But if you send them home, those events get missed. The bradycardia that no one saw that didn't have any clinical meaning that otherwise would have been seen in the hospital. It is an interesting phenomenon.
I'm sure machine learning will make this all clear for us in the near future.
Yes, of course.
All right. I'm going to talk about the next article here. This is called the Ambulance Cardiac Chest Pain Evaluation in Scotland Study, ACCESS, a prospective cohort study. Lead author here is Jamie G. Cooper, and they are at the Aberdeen Royal Infirmary. It's been a long, strange trip these last couple decades. We've circled back from potentially sending every chest pain patient to die inadvertently, like the late 90s, to admitting every single whiff of potential acute coronary syndrome, like the 2000s, to this, experimenting with not even transporting patients with chest pain to the hospital. So this is the ACCESS study in which paramedics calculated HEAR scores, which is like the heart score without the T, and heart scores in the pre-hospital setting. That is to say, they used this heart with accepting the troponin value initially, and then in some cases used a point-of-care analyzer for the troponin measurement. Between 2014 and 2018, 85 paramedics obtained consent from 1,275 patients with suspected acute coronary syndrome. 220 of those ultimately withdrew, leaving 1,054 for analysis. And then their point-of-care analyzer was only available and with verified quality control for the first 357 patients of this. So there's kind of a sub-study within the study of sorts. The primary outcome was major adverse cardiac events at 30 days. And then out of this entire 1,054 patient cohort, 269 had an adverse cardiac event at the index presentation, and 15 more suffered an event within 30 days. So, as you might expect, low heart scores were fairly good at ruling patients out, and high heart scores were fairly predictive of adverse events. The problem, however, this sort of fairly good at ruling patients out, is that the heart score as applied by these paramedics in this setting was a heart score of 3 or less was only about 80 to 85% sensitive for 30-day major adverse cardiac events as implemented. It's probably not feasible to have paramedics go and do a point-of-care evaluation on patients in the outpatient setting with a sensitivity of only 80 to 85% for 30 major adverse cardiac events, let alone before determining whether any additional alternative diagnoses ought to be considered in a patient with chest pain. I kind of like the idea of doing point-of-care troponins on people and doing a point-of-care risk stratification, but maybe there's a way to refine the application. Undifferentiated chest pain patients being picked up from home are different than patients at a primary care office, perhaps complaining of an atypical chest pain for which an acute medical evaluation has already been performed, and they're simply asking the narrow question of excluding an acute coronary syndrome. A paramedic with an ECG and a point-of-care troponin could easily answer that sort of narrow question. But I'm not sure about this general application, at least not as described here. And the other question the authors ask pertains to whether this pre-hospital evaluation might have the specificity to guide triage to cardiac centers. This seems like potentially a reasonable approach, particularly in systems like mine, where patients are frequently directly admitted or triaged to specialty services, or they can bypass a community hospital straight to a tertiary center with cath lab availability and sort of interventionalists, rather than coming through a general emergency department or having a subsequent transfer.
At first, I was like, why are we doing this? It does seem like it's a fairly complex thing that we're asking these paramedics to do. As you said, there's alternative diagnosis, so it's not always straightforward. I did say it was interesting on looking at the use of the HEAR score without the troponin. Just can you clinically risk stratify these people in cases that you don't want to get a troponin, and performed as good or as bad as it did with the troponin, essentially, which was somewhat interesting. My concern about the triaging the high risk patients is you start getting that trauma system triage, where we all know you start getting massive over triage to places with some of these patients, because even the high risk group wasn't perfect, and it was such a low actual total amount of patients that I wonder if it's really a useful strategy.
Yeah, I mean, if they're finding that in their particular system or whatever healthcare system that you're in, that you're ending up with adverse events and a whole bunch of transfers, and I'm giving thrombolytics in the outpatient setting and transferring for rescue PCI or just for monitoring, maybe this might be valuable. So it's like your system's going to have to evaluate the potential value of this and the potential adverse events it might prevent for a little bit of over triage and resource or shifting. But yeah, as far as just like a basic, like let's rule everybody out for acute coronary syndrome without transporting them to the hospital, I don't think we're quite doing that, at least not as a sort of like without some sort of better oversight or clinician involvement or just a different protocol.
Yeah, I think that's fair. I would just add, I'm not sure if MACE is an appropriate score to identify high-risk patients, right? Most people with a MACE still don't need to go to the cardiac center and, they can get their revascularization wherever they get their revascularization. So maybe looking at CRACE or some other form of higher clinically significant disease outcome would help us identify the right patient.
Yeah, or just making sure that they don't even miss the first sort of index visit, cardiac outcome, let alone the 30-day one.
Yeah, indeed. All right, let's move on. So our next article is routine laboratory screening for acetaminophen and salicylate ingestion in pre-admission psychiatric patients is unnecessary. The lead author is Andrew Farkas. So I think we've all been exposed to the excessively laborious medical clearance exam required for patients evaluated for psychiatric complaints in the emergency department. And the majority of the literature shows that ordering a pre-specified bundle of laboratory tests on these patients is generally low yield and adds nothing to the medical screening. But what about screening for salicylates and acetaminophen ingestions? These authors sought to assess the utility of a acetaminophen and salicylate level as routine screening labs in psychiatric patients presenting to the emergency department. They conducted a retrospective multi-center chart review at 3 urban VA emergency departments. During this period examined, all 3 hospitals required both acetaminophen and salicylate levels as part of their routine screening process for any patient being evaluated in the ED for a psychiatric complaint. The officer identified all patients who had salicylate and acetaminophen levels drawn during the ED visit. Then via chart review, the officers determined if the visit was due to a psychiatric complaint. They identified 16,907 acetaminophen assays and 16,673 salicylate assays performed on a little over 10,000 unique patients during the study period. Of the 16,907 encounters, 10,152 had a chief complaint that was psychiatric in nature. Overall, there were 43 cases of supertherapeutic acetaminophen ingestions and 11 cases of supertherapeutic salicylate ingestions. 1 patient had a supertherapeutic level of both. A total of 6 supertherapeutic assays came back on patients for whom there was no known history of overdose prior to the levels being set, and with the levels having been apparently ordered just for psychiatric screening. None of these 6 cases did the elevated level reach toxic thresholds, and none required any antidote or medical admission. The authors go on to document in detail the clinical courses and outcomes of these 6 patients in the manuscript. So all in all, I think it was a pretty well done study. We can nitpick on the fact that it was a chart review, and because of this, it's difficult to assess when levels were clinically indicated or not. But I think the results fall in line with everything we know about psychiatric screening. Without clinical indications, these labs are, for the most part, useless.
Yeah, I mean, this is beautiful. I mean, there's just so many cases involved in this study. 33,000 combined acetaminophen and salicylate assays. And yeah, I mean, there's some positive values, but none of them are clinically important. At the minimum, their statement is absolutely correct. They're very reasonable. Like if there's any suspicion, you can use a doctor can figure this out. There's not like this concept that you're taught in medical school that you can't trust a patient, especially a psychiatric patient, about their ingestion history. That comes from a dark place. It turns out, yes, you can actually, in many cases, accurately assess a patient and their risk for overdose. And in the ones where there's any sort of doubt, you could also still err on the side of being cautious. And you would still not be sending patient, assays on, that would probably still cut out 90% of these unnecessary tests to just do that. So yes, it's too bad. They mentioned these are inexpensive tests in the VA system, like $1.50 each, but still, 30,000 times $1.50 is not free. And then the charges, obviously, when you actually get into the health system and you end up with all these different middlemen trying to take their profit out of the system, it's obviously much higher.
Of course. So, despite this well-done study, do you think this is going to change practice at all?
Hey, at one point, we didn't think that we would be able to use intravenous contrast in CTs ever, for people with a little bit of renal insufficiency. And look where we are today. There's always a chance.
Yeah.
Come on, Rory. Let's have a growth mindset.
The problem is it's not the emergency physicians. It's the psychiatric clearance. I think this needs to be in a psych journal rather than the EM journal.
Oh,
right?
well, the radiologists had to make the decision and put it in the ACR, guidelines to let us use intravenous contrast in renal insufficiency. Psychiatric, they could choose wisely. We could add this into one of their sort of ABIM movement sort of things. You never know.
One can hope.
You could hope. All right, the next great article in this great issue, intravenous haloperidol versus ondansetron for cannabis hyperemesis syndrome, the HAVOC trial. Lead author here is Aaron J. Roberto, and they're at Queen's University. I almost feel like I don't even need to present this. I mean, I have all these notes on it, and I'm like, well, could I do my spiel, or could I just say, well, duh, because we've all been doing. I mean, I guess not every state has such profound experience with haloperidol and in cannabis hyperemesis as some of us do.
Yeah, I mean, the only shocking thing is, this is an article published in Annals and it doesn't have druperidol in it.
We do have to talk about the article. And one of the things I was going to mention here is that a few weeks ago, there was this XKCD comment circulating describing different types of scientific papers. And it was sort of like this viral meme where each specialty poked fun at themselves, and emergency medicine being one of them. And here we are, like in emergency medicine, all too real. It's like the randomized controlled trial with fewer participants than a soccer game. I mean, it's a randomized. This is like typical for like the RCTs in emergency medicine. Like, as a little bit of an exaggeration, poking fun at ourselves that our RCTs have like 20 to 30 people in them, and here we are.
So true.
It's definitely one of these topics where anecdote and other limited evidence has already dramatically shaped practice, as each of us working in settings where cannabis use is prevalent has already witnessed repeated treatment failures in hyperemesis, and we've all gravitated towards using haloperidol or something like it. Essentially conducting parallel N of 1 trials. All of us just, continuing to, try haloperidol and so on and so forth. So the design here is actually quite interesting. They randomized patients to either intravenous ondansetron 8 milligrams or to a haloperidol arm, which had a further nested randomization to either haloperidol 0.05 milligrams per kilogram or haloperidol 0.1 milligrams per kilogram. And then part of the expectation here was that patients receiving one treatment, because of the nature of this disease, they would ultimately return in the future and be crossed over to the alternate arm for comparison, which I love, but they tried. The primary outcome was change in abdominal pain and nausea scores at 2 hours, at which point rescue therapies could be instituted, and authors likewise recorded such outcomes as length of stay and adverse event. Over the 2-year period, they only managed to pull in and treat 30 patients, and then only 3 of those returned and checked all the serious boxes necessary to be incurred as a period 2 crossover treatment, limiting some of their initial study design. However, even with these 33 visits for analysis, one thing was dramatically clear. Ondansetron does basically nothing for these patients. Half the haloperidol patients met their criteria for treatment success, where only a quarter did receiving ondansetron, and this is reflected in all the various point scale measurements for nausea and abdominal pain. There were 3 patients who returned out of 15 treated with haloperidol with complaints of akathisia, acute dystonia, and all of those were in the 0.1 milligram per kilogram haloperidol cohort, which is a pretty big dose of haloperidol.
Yeah.
So there's virtually nothing surprising about these data. Pretty clear when haloperidol or droperidol are among our best options for treating cannabinoid hyperemesis. The best question is probably a dose-finding one. 0.1 milligrams per kilogram is probably too high. 0.05 milligrams may be in the right range, or they may even be a different dose ceiling for its therapeutic effect and balance between adverse events and efficacy. And I think that's probably our best next direction on investigation to improve tolerability and efficacy of this treatment.
The more studies we do on the efficacy of ondansetron, the more it becomes clear it's about as good as placebo and not as good as an alcohol swab in the nose. So one has to wonder what you're actually testing it against. But, any study that supports the use of haloperidol in any treatment, I'm for. So, hurrah.
Yeah. 0.1 milligrams per kilogram can get to a pretty good dose for some people.
That's impressive.
It's not like, it's clearly not a fatal dose, but, I can see how the adverse effects are ramping up a little bit. And it's really trying to balance its efficacy versus the adverse events that we know its known adverse effect profile is probably sort of the next sort of, if we can get more patients involved, would be a nice thing to check out.
Yeah, it would be good. Almost like the ketorolac studies where you do a number of doses and see where your therapeutic ceiling is.
Exactly.
All right, let's move on. Our next article, moving from haloperidol to TXA, the use of tranexamic acid to reduce the need for nasal packing and epistaxis, the NOPAC randomized controlled trial. And the lead author is Adam Rubin. If you have a problem with bleeding, then I have an answer, and it's almost always TXA. Since the publication of CRASH 2, TXA has been proposed as the miracle cure for almost every ailment that bleeds. And despite a number of trials showing its ineffectiveness in such things as postpartum hemorrhage, spontaneous subarachnoid, TBI, and others, TXA has managed to maintain its perceived status as control of all things bleeding. A number of small studies have suggested that gauze soaked in TXA is a very effective method for controlling difficult to stop nosebleeds. So these authors conducted a double-blind, placebo-controlled, multi-center, randomized controlled trial that was conducted across 26 emergency departments. Patients were randomized to receive a dental roll soaked in TXA and then packed in their bleeding nostril for 10 minutes or one soaked in sterile water. If bleeding wasn't controlled after the first administration, a second one was permitted. A total of 496 participants were randomized, 254 in the TXA group and 252 and 242 in the placebo group. Overall, 43.7% of the participants in the TX group failed the gauze-soaked roll and underwent anterior packing, and 41.3% received anterior packing in the placebo group. There was no other secondary outputs that seemed to point towards TXA's benefit. So it's a fairly negative study, and one could argue that it was underpowered, but there's not even really a signal of benefit for TXA. One could also argue that maybe it's not applied correctly. Is 10 minutes really enough time? It is a question of external validity. A large portion of these patients were admitted to the hospital. It seems out of proportion to what, my clinical practice is. Most of these patients are discharged home. That being said, it's about as negative as a study could be. And so until someone shows that TXA has a benefit in these patients, it's kind of hard to justify its ongoing use.
Yeah, clearly TXA is safe because it barely does anything at all to start with. So it's really hard to have a serious adverse effect profile, and it's really hard to have in a topical formulation even, let alone intravenously. So you can't say that it's a bad idea to try to continue to develop treatment protocols incorporating TXA, but obviously the way they're applying it here and the way they're using it here is not working. Honestly, from all our TXA trials, the magnitude of effect that you're going to find should be expected to be tiny regardless.
Right.
It's like every single, the woman trial, the various head injury trials, the CRASH 2 trials, every single CRASH 3, you name it, the effect size is a couple tiny percentage, points, if it even reaches statistical significance. If you're going to design a trial for nosebleeds, you probably would also likewise not expect to have more than a couple percentage points different. So the non-significant effect size may actually be its true effect size of, 1.2% difference or something like that. So it's possible that there is a true beneficial effect, but it's just so tiny that it's not clinically meaningful. And you might as well just spend your time in the emergency department with a greater chance of affecting your final outcome.
Yeah, I always joke about TXA. In order to find a positive study, you need 20,000 patients, multiple secondary endpoints, and you'll find something that's positive, right? But unless you do that, you're never going to find a benefit for TXA.
Probably for freckles. That's what it's for.
Yeah, indeed.
Yeah. Okay. The last article we're going to mention from this issue is a really quick one. Does the clinical frailty scale at triage predict outcomes from emergency care for older people? And the lead author is Amy Elliott, and they are at the University Hospitals of Leicester. So this is a pretty straightforward retrospective study with a really simple answer. So I'm not going to belabor it unnecessarily. Did elderly patients with higher frailty scores have worse 30-day outcomes? Higher chances for admission to the hospital? Longer hospital length of stay? Hospital readmissions? Death? Pretty much all those things, yes. There are a lot of statistical adjustments performed as a part of an attempt to quantify the relative risk of each frailty category, but I wouldn't call those estimates precise enough to incorporate it into any sort of clinical prediction. But, obviously trying to put the frailty score into some clinical context, it's potentially useful to note patients with frailty scores of 4 or greater were admitted around 70% of the time. But there's obviously some collinearity with age here, as well as probably multiple medical comorbidities as well. And then in that sense, it could be potentially part of some sort of operational forecasting to have frailty scores collected at triage if you're trying to sort of anticipate flow through the department and the downstream resource needs and the inpatient flow and the sort of nursing staffing you're going to need overnight and those sorts of things. It may be just as good or even better than some of these sort of machine learning dashboard things that they keep coming up with. I would only risk to sort of say that as much as predictive as the clinical frailty score might be, adding yet another thing for our nurses to gather at triage. In addition to all the other scores and screenings they have to do already, it's just further burden to the emergency department assessment, which is only increasing as opposed to the other way around. So before trying to incorporate this score into practice rather than to research, there should be some better data as far as implementation trials.
Yeah, I mean, that's the big thing here, right? Like the amount of things nurses have to do at triage and have to record already is just so overburdensome. Just to add another one, that we're not even sure how it helps. This is like many of the other articles that, there's an obvious association with the higher the frailty score, the worse the patient outcomes. That's unsurprising. But does it actually tell us anything we need to know? Like, does admission actually help these people? Or is it just a result of the actual disease burden that the patients have? And then more importantly, is it better than even simpler prediction scores like 100 minus your age, which is, a definitive absolute truth that we all know in emergency medicine?
Just about. And then you start recording these scores and start thinking about it. And does the score start to drive your practice? And you're like, oh, their frailty score is like 5. That basically means they're going to have a really poor 30-day outcome because they're so frail. We should definitely find a diagnosis to admit them to the hospital for. And then it's a self-fulfilling prophecy.
Right. I mean, you record a score, people are going to act on it, right? So
yeah, I mean, it's like SIRS and it's QSOFA. It's like, oh my goodness, the score is so high. They must have sepsis. We must admit them to the hospital. Wait a minute, that's the score driving treatment, not the patient driving treatment.
Right. But I do think it might have its use, looking at the frailty score and using it to look at outcomes of disease processes like sepsis and trying to figure out how many people have sepsis because of their frailty and other disease burden versus how many people have a salvageable disease that we can fix would be an interesting way of using the score. But using it at triage to help predict and drive admissions, probably not a good idea.
All right. We hit the highlights from June.
Yeah, it's a great issue. Everyone should read it.
These are fun articles. So yeah, if you want more detail on anything that we talked about, that you know where to find it.
Yeah. Well, that wraps us up. So until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.